Welcome back to the Group Practice Accelerator podcast, brought to you by Polaris Healthcare Partners, where we leverage decades of healthcare and business experience to drive growth in successful group practices just like yours. If you're a healthcare entrepreneur and you're interested in building, scaling, or exiting your group practice, you've found not only the industry's leading resource for business education, but a team of trusted advisors dedicated to helping you achieve and exceed your goals. In short, the team at Polaris creates clarity, confidence, and results. I'm your host, Jamie Falosh, and the Group Practice Accelerator podcast is on the air. Hey everyone, thanks for joining me today. We've got a great episode in store, and this one's a note taker because if you happen to notice the title of today's episode around developing your associate to produce $1 million or more annually, I'm sure you're wondering just how to make that happen. So before we get into it, I'm going to back up a little. As you recall, Polaris launched a hands-on on-site clinical coaching program early this year, and I want to take a moment to review why we did this. So first, while there are so many wonderful hygiene coaching programs out there that I can attest to, there is a gap in the market when it comes to true on-site, doctor-to-doctor, peer-to-peer coaching. For our smaller groups, a principal doc leaving the chair to try to implement a robust development program for his associates that has lasting benefits to EBITDA can have a real impact on production. So he or she may never realize the gains of a program like that. And one could argue that, yes, larger groups often have clinical directors and even regionals overseeing their docs, but we know that although they're wonderful leaders in their own right, often their time is spread really thin throughout the organization, and one-on-one mentorship can be really tough, if not impossible in some cases. Many even provide weekend courses hoping to introduce new skills, and that's with the best of intentions, of course, but we know that without continued support, those newly learned skills very seldom stick, and they just don't become behaviors that last. So we're missing out on benefit to the practice and bottom line there. Second, from that gap in the market arises an issue from a business perspective. Now, as I mentioned, when we launched the program, it's simply not possible, we know, to separate business from clinical, nor would we want to. And that cascade from graduation to clinical career advancement and the type of dentistry docs provide to confidence in case presentation, to closing cases, and even recruitment and retention, well, all of that pools in the same place, and that's your business. More specifically, the value of your business. And doctor development doesn't happen spontaneously, unfortunately. We know that genuine on-site mentorship can have a tremendous lift on a doctor's production and further gives your business a competitive advantage from, multiple angles when doctors are set on that kind of trajectory. So given that why, our mission to accelerate growth in that business that belongs to you, let's get to today's topic. And here to dig into how you can develop those million or million plus doctors is someone who has firsthand experience in doing just that. He's not only built his own group success, but he knows how to build doctors. And that's my teammate and Polaris Clinical Coach, Dr. Vivek Solanki. Vivek, welcome back to the show.
Hey, thanks so much for having me.
Yeah, good to see you.
Absolutely.
So, we have a lot to cover today. But we better lay some groundwork. I think it's only fair that we start breaking down kind of a baseline for our listeners. So if we think of that $1 million associate, right? And more, of course, because we want to get there. Let's begin with the average doctor in a GP practice. And that falls anywhere from, correct me if I'm wrong, like $600,000 to $7,000 a year in a production.
Yeah, that's what we see on average in a mature practice for a 4 to 5 day week doctor. Basically a full-time schedule for that general dentist.
Good. Just checking my math. So if you or your associate are producing $3,000 a day at 4 days a week, and that's $12,000 a week times 50 weeks, which gives us $600,000 a year. So I kind of went on the low end with that. Or
that's correct.
Yeah. So $3,500 a day, 4 days a week brings us to $700,000 in production. Now, we're looking to increase over time, of course, our annual production for that doctor by $300,000. That's a pretty big leap. It's a meaningful increase that doesn't happen all by itself. So if we want to get to that million or more, we've got to have a rock solid system in place. So you and I have talked at length about your processes and how you've been able to get docs to that million plus in production. And you've been able to very efficiently and effectively reproduce it, which is the most critical part. So, said differently, you've been able to create success not only in your own group, but with others as well. Why don't we
Mhm.
start by talking about the steps that you take to get there, get to that $1 million plus producer, and then after that, we'll break them down one by one. Sound good?
Yeah, yeah, absolutely. Let's talk about step one. You touched on some really great things in the introduction. I really loved hearing that because there's so many doctors who will invest in a cone beam, which becomes wall art, or a CEREC machine, which is an ornament that's going to be in the office. And these weekend courses, they just don't work that well when you're trying to push advanced dentistry, which requires surgery, implant work, treatment planning. And so step one in this process is really about understanding where the doctors are at. This is where the on-site component really comes in play.
Okay.
We go there and we spend time with the doctors, connecting with them, understanding what their goals are, where are they at in terms of the basics? How do they present treatment? How are treatment plans presented in the office? Because we haven't even got to doing treatment yet. But in order to be successful at executing treatment outcomes, the systems that surround it need to be equally as effective. So, what is their treatment planning process like? How are they navigating treatment? What tools do they have in their box to help the patients and thereby provide better care in that practice? So there's a big deep dive that goes in the beginning to
Mhm.
really build that trust, like letting them know I'm actually here as a colleague, I'm your comrade, I'm here to help, and let's sit down and do this together. So this understanding is so crucial to what happens down the line in step twos and threes.
Okay. Well, why don't we start there? So, if we just take those three steps, let's break down what we can even call assess or observe. We need to start from that foundation before we can get anywhere else. So, how does that tie into subsequent steps that really builds from to get to us to that $1 million mark?
Sure. So an assessment would be spending time in a clinic day with a doc, shadowing, standing behind. We're not in the room with the patients, but standing behind, listening to, understanding and listening to how they're treatment planning. What are they looking at with their diagnostics, with their x-rays, with their cone beams? Understanding why they want to treatment plan a case one way when a patient may say or want something completely different,
Mm.
or are these doctors just uncomfortable talking about specialized care or the care that they would want in their own mouths or their family's mouth? Is there a people, patient, process issue, which I know we talk about so much
We
at
do.
Polaris? And that factors in. Why aren't they succeeding? That's assessment. What is the issue, the root underlying cause that is preventing the doctors from doing the type of treatment that is going to excite them? And generally, the better treatment sometimes is going to be sometimes more expensive. It doesn't always have to be. A denture could be a great treatment option. It's a lot cheaper than an all on X, but really helping them understand and communicate to the patient what the options are, listening to them on what they want, and then to see, is there a disconnect between the treatment plan that they want to present to the patient? Is there a disconnect in how it's conveyed, and getting to that yes so that we can start treatment efficiently to get it done? In a nutshell, that's really what happens in step one, is really understanding what the issues are and then coming up with a plan of what to do next on implementation.
Hey, on that, quick question. When you're in this observation stage, do you often find that there's some hesitancy with docs to deliver what can sometimes be perceived as really expensive care? And I'm air quoting here because it doesn't mean that it's not what the patient need just because it has a higher price tag attached to it.
Yeah, that's a great question. So many doctors will assume, well, I don't think they can afford it. I
Mm,
hear that so often.
yeah.
And let's talk about something so simple. They're doing a buildup in crown, and they realize that that crown prep is on bone on 25% of that margin. And they're just afraid to tell the patient, hey, we've invaded biologic width. And now they're backtracking. They either leave the margin down there or they try to do some sort of gingivectomy or something, and they're just afraid to tell the patient, hey, we need to do crown lengthening here. Where we could prevent something like that would be, let's sit down and look at the diagnostics. What are the different sets of scenarios that could happen here? You know, there's an existing crown on here, there's decay under this crown, and there's a chance we could invade biologic width. So while the dentist themselves feels like they're doing the best thing for the patient, going slowly, taking a lot of this time, and then, oh shoot, we pulped out for a root canal, or oh shoot, the margin is now on bone. I tried so hard, but the patient doesn't know that because all the patient was told is that you need a buildup and a crown.
Right.
They weren't told when we take this helmet off and we take the decay off, there's a chance that that helmet's going to be sitting on your bone. It's going to hurt you. So we need to do this procedure called crown lengthening. We need to make the tooth a little bit longer so this helmet's going to sit on there and it's going to be something you can keep clean. But they've been told up front, and we do drills together. That's part of step two, but we do drills together where we get comfortable in helping doctors have these conversations so it's not uncomfortable for them. That makes the treatment so much less stressful for them and navigating, instead of these oops moments. And now I have to go back and tell them they have to spend more money, versus helping them know that if we don't have to do this crown lengthening, you now look like the hero because you've told them about it from the get-go. And you don't need to do this procedure because you were able to do the crown prep satisfactory without invading biologic width. Just as a simple example.
Yeah, that's a good analogy that you made because it has to play into the whole observation process when you're standing back and you hear someone not want to deliver the full package because they're worried about the monetary aspect. From my perspective, and keeping this kind of segmented to my experience in hygiene, is oh gosh, this patient can't afford this. And you have it in your brain, but you really have to turn that around in either case, whether it's dentistry or hygiene or what have you in healthcare. Is would I present it that way if this was my family member? Like,
Exactly. Or if it was no exchange of money, what's the right thing to do here? And what's the best thing to do here for
right.
success and longevity?
Agree. Agree. Well, you kind of hinted at step number two. So why don't I let you elaborate that? So now you've gathered all of your intel and you've got to deliver it. What's next?
This part is really fun. It's hands-on coaching now. Drills, drills, drills. A lot of treatment planning. We do these really fun sessions together where we'll throw up so many different scenarios of full mouth rehabs. Here's the CT, here are the x-rays. Here's a single tooth x-ray. There's perio disease. Like, give me a treatment plan. And okay, patient says, I can't do this. In your head, what's the next best thing? So, like, helping people stay on their toes, because meanwhile, the patient is judging the doc. They're judging this confidence that the doc has when they're having these conversations. They're trying to assess the patient, at least, they're trying to assess, is this doctor competent and confident and comfortable handling my situation? That's what the patient wants to know in the chair. So when we do these drills, the drills have the intention of these drills is to put a process together that's going to simulate not the perfect scenario, which is what rarely encompass, but how do we call an audible if we need to? And how do we talk about things that could happen down the line? And how do we encompass this all into something that is so simple for the patient to understand, and that the doctors are happy and comfortable with their treatment plan, so that the treatment coordinator or the finance coordinator can just go in and get the patients on the track so doctors can start doing treatment. That's just on the treatment planning and the case acceptance side. On the drills and the coaching sessions, sitting down with somebody with a pig jaw or taking a team to a cadaver course and practicing dental implants the way we were taught to do it, even crown lengthening. I will routinely bring models and have doctors do crown lengthening with me the same way we would with perio, or place implants how we were taught to place, and get them a chance to learn, some sort of proprioception and navigating around models before I'm their assistant chairside on these on-site visits. Book some surgeries today and I'll be your assistant, and we'll talk about these cases where now I'm having such sophisticated conversations with these doctors. An example, they don't want to scallop too much tissue because they don't want to cut all the attached tissue away. And it's nice because you see them develop and they grow. They're in this comfortable environment. They mature and they grow so fast. And so there's usually a 30% bump that I initially see within the first 6 months of getting started. And some of these people, these doctors, are able to double their baseline productions in a matter of 8 to 12 months on average.
And really, let's call it what it is. It's developmental boot camp. You're practicing these drills, you're implementing these things in real time. And the benefit of having someone sit chairside with you as you go through this, that's a completely different world than taking a weekend course like we talked about earlier, where you go back and you don't have anybody there mentoring you and walking through this process with you. So just the confidence you get knowing that this is a team effort, and it's a team effort meant to build your skills, and by default the practice. I mean, that's a great value that you provide, and it's obvious why you've been as successful as you have been.
Yeah, thank you. We talk a lot about surgery, implants, crown lengthening. We talk a lot about these adjunctive procedures that can help restorative. There is certainly other aspects of dentistry that can help a doctor in their clinical outcomes, with Invisalign and ortho, with Dr. Steve and their sleep medicine. There's so many facets. What I'm trying to come at this approach is, if you have a general dentist, many general dentists desire to do their own surgeries. They want to know what they can do comfortably and well and what they can't do. And they enjoy learning crown lengthening, implant placement, perio services, extraction grafts that could supplement their bridge prep or their restorative plans. And just those few things on average is enough to have a $5,000 to $8,000 a day doc on a routine day. This is not seeing 50 patients in a day. This is seeing a normal schedule of 8 to 10 patients, sometimes more or less, depending on what the production is there. But you've just increased your toolbox. You've increased the amount of things that you can provide care for your patient, but it's geared towards helping them execute what their treatment plan is, because they're the quarterback. The restorative doctor is always the quarterback in these cases.
That's absolutely true, and that's a meaningful difference. We're not talking about a few $100, we're talking about a few $1,000s.
You're right. And I'm so happy you said that, because at the end of the day, everybody has to win from this.
Mhm.
The patient, number one, needs to get the best care. And you touched on that meaningful bump of an extra $1,500 a day in production on a 4-day work week is on average about $300,000 a year in production for a doctor.
Right.
That's an extra 100,000 to $120,000
Mhm.
of take home for that doctor. And like, how is that going to change their family life? And for the business owners, let's just say that another 100,000 in pure EBITDA that's going back into that business.
Right. I mean, our operating expenses are pretty well fixed at that point if you're just expanding the type of dentistry you're providing, correct?
You still have dental assistants, you still have chair time. We're just changing the quality of the work that's being done in the office to help patients get better care.
Yeah, definitely. Let's hit step number 3, implementation. So now we've checked off 1 and 2. We've got buy-in from the doc. The drills are going well. It's showtime.
So implementation, we do chair side. So, there's on site, we do the Zoom visits, and implementation is walking through somebody on their game plan. What's the approach today? How are you going to sequence your treatment? When we are on site, we get to do a lot of chair side with them. So we'll suction, we'll watch, we'll help treatment plan cases, and we'll be there to help make sure that their cases go well. And after the first few months, we start to see docs say, like, I got this. I don't need you right now. I want you to watch this one from afar. And they follow the same protocols. We do everything in the surgery world and implant dentistry world. Everything is about safety
Mhm.
and about doing things correctly to avoid adverse outcomes. So we put protocols together that they can follow and implement that are going to be checkpoints: when to drill, when to stop, when to take your x-ray, and then what to do next. If you have to re-angle, if you have to recorrect, and we do all of these drills in the previous step, in step two. We provide simulations where they have to change and they have to move their drill sequence and go back a step so that they get comfortable when things move off the normal path. And in implementation phase, we do it chair side and we watch to make sure that they understand those concepts, because once they understand, it's not necessarily memorization. If the doctor really has a true understanding of it, you'll see everything change. You'll see their treatment planning change on their own, where they'll start thinking, we could do this or we could do this, but I want to save the tooth. I want to crown lengthen this tooth because of these factors, the health history, or because I don't think that there's enough bone to place an implant here. So a bridge prep, this is a perfect place for a bridge prep, right? So when they get that deep level of understanding, the implementation phase is what we monitor, and then we keep in constant contact, because then we've established this relationship with them that we can help them move to a next level of growth where they're maybe able to take on more challenging cases in their practices.
Well, in mixing the on-site Zoom check-in, all of the drills and things that we've talked about today with these three steps, I mean, that creates the relationship. When they know that they can lean on you for that mentorship, it just makes a huge difference. And we know that getting stuck in that 600, 650, or even 700,000 in production range happens all the time.
It
And
does.
we're solving for that, but I want to take that a little bit further because we talk a lot about recruitment and retention on this show in various frames. So I want to pause and take a look at what the right mentorship and development does for our listeners' practices, because from the associate's perspective, if we stand in their shoes for a minute, when we're invested in developing them as clinicians, as leaders within the practice, well, that's a really attractive recruitment tool right there. And then, not to mention the retention perspective. They can pay their student loans faster, they can develop their skills, their confidence. So, this type of hands on continuing coaching is a value add for your business if you look at it from that perspective.
It is, I agree. And if the principals or these groups that have an internal system, if they can't directly coach them and teach them to help their doctors develop and help their businesses grow, then they have to engage a coach. They have to engage somebody that's going to help provide the what's needed. And a lot of doctors and a lot of the associates that are in group practices, they strive and desire to learn. When they go to these CE courses, you can see the excitement in their faces. But when they come back, how are they supposed to do this after a weekend course? They start thinking lawsuit, legalities. What if I mess up? And
Right.
then the mind is now clouded with all this fear and this risk adverse. And that's not a conducive environment to learn. Whereas here comes in somebody who's going to do some simulations with you, who's going to be chairside with you, and that comfort level keeps those thoughts at bay. And then it allows somebody to learn in a clinical setting, even in private practice. It allows them to learn without patients feeling like they're in a residency program. Like, this is a very sophisticated and a professional environment that doesn't make the doctor look less than the doctor that their patients perceive them to be.
And the point that you just made on confidence, you come out of these courses and you're flying solo from there. So I cannot stress the value enough of having someone there to mentor you on site, but still maintaining that position that you hold within the practice where the patient sees you as the expert because you are. And we certainly want to support that in every way that we can.
Absolutely.
Vivek, we talked today from a GP perspective about how to develop an associate, get to that million plus mark. I think next time we should cover the specialty model, meaning incorporating specialty into that practice. Does this also work well in a specialty model, though?
Absolutely. Absolutely, it does. It works well in specialty model. There's always things that specialty can grow and change. Group practice and the dental space is evolved so much in the last 10 years. I think what's been very helpful for me is that I've had such a vast number of positions in clinical care. I've been in solo specialty practice. I've owned over 10 general dentistry practices in my career. My job revolves around making other people succeed around me. I don't want to be in the spotlight. For me, when I look at a business, the business should be growing, and I would like to see other people get the wins. And I'm in the shadows. I'm their cheerleader. I'm behind the scenes. What's happening to help the doctors grow? Who's mentoring them? Who's providing that leadership? Who's there as a sounding board when they're having a bad day or when they're stressing out about a clinical outcome,
Mhm.
but then they go back refreshed. They go back without those thoughts in their mind, and they can use those adverse experiences as a means to fuel their growth moving forward. So that's always the approach that I've taken, and it's served me well in private practice.
It's been so fun learning about your success since I met you. And that was just a perfect breakdown, I think, of those steps to get there. Obviously, that's the tip of the iceberg. But we always appreciate that you've already walked in our listeners' shoes. And that holds tremendous value, as does your take on this. Can you give us some final thoughts? Maybe share a story that our listeners can relate to?
Absolutely. This is very, I guess, tangible to what our audience has. Is when I first moved to Florida and partnered with a colleague of mine that's been a great friend of mine for 20 years. The two offices that he owned did about 1.2 million in revenue, and two doctors, with him being the principal and one associate. The associate was about a 450 to $500,000 producer a year, and really had a, I wouldn't say a fear, but really had just an uncomfortable, a little bit of uncomfortability with navigating into the surgical world, implants, surgical extractions. And now we fast forward 2 years into this journey where the same two practices, there's with multiple more that are running well, but those same two that did 1.2 million in revenue are now doing over five. How is that? Because we go back to those people patient process. And when we drive those patients into the practice and you have good systems, we can now expand. There are now four general dentists from the original principal and the associate. The associate that was there is one of the strongest providers in the group. He doesn't need me here for single implants. He can restore all of his full arch. I can come into an office and do a full edentulation, place 10 implants, and just leave. And knowing that he has the comfortability and the experience to do a conversion himself chairside so that the patient can go home with teeth in a day. So now how do you get to a place where somebody was afraid to do a surgical extraction
Mhm.
and now they're placing implants, producing $1.3 million a year, and they're doing full arch. But they have learned so much that they are now mentoring other younger doctors.
Oh,
He's
wow.
now mentoring other younger doctors that come in because you learn more when you teach. That's what they say. And it's true. Well, you really learn more the most when you have to teach something to somebody. And so it's just been so like gratifying watching, everybody develop and grow. And it's all about the culture that's created there. But the same thing that we are talking about with the steps of clinical coaching and clinical mentorship, right? We mentioned either you do it yourself Either these principals do it themselves or they need to find somebody to come in and do it, because days are gone where you can just keep buying offices and hope for arbitrage when you go to market. That's not what people want to see. They want to see growth, 5 to 7% at least year over year in an office. They want to see that there's a pathway for doctors to grow and get better. And then how do you give these doctors JV structures if there's no pathway for them to grow in their clinical careers? So you can't, like you mentioned before, it's really accurate statement. You can't really separate the business and the clinical, but it's just that everything that I've done here to grow my businesses has always come from a clinical lens. What can we do to help our patients? Let's do the best possible care. And then how can I teach everyone around me and bring them up with me? And then now let's talk about the systems and driving more patients into the practice, because we know that the doctors are capable of providing excellent care.
Absolutely. And this reminds me of the last episode that you and I did together that relates back to this example, the story that you just told on delivering different tranches of dentistry, developing that
Mhm.
skill set to a different level where your production is just multiplied. It's not just bumping up a little, it's multiplied. And what a huge impact that had on their business. That's incredible.
Yes.
Like you said, I know you don't want to be in the spotlight, but I'm going to say it anyway. Kudos to you and your coaching abilities. But I wholeheartedly agree with you. It's a learning process when you are the coach.
Yeah, the best investment is in human capital. And when the point of bringing associate doctors into a business, and I like to call it better than my teammates here, is that if there's a way for them to grow and learn, they're going to be much more passionate about the business versus somebody else who doesn't get that level of mentorship. And that's the culture, because they are predominantly the ones that are there day in and day out, that are providing the care. And it's the least that we, as owners and principals and management teams, it's the least that we can do to support the people that are providing one of the biggest impacts in the business.
Absolutely. Well, Vivek, we certainly appreciate your insights here today. And I'll say it again, the fact that you have walked in the shoes of our listeners makes it that much more impactful.
Thank you, Jamie.
Well, many of our listeners will no doubt have some follow-up questions and want to get in touch. And I know you're ready for them. So if you'd like to learn more about on-site clinical coaching and mentorship, or talk about any of our Polaris expert advisory services, or maybe there's a topic we haven't covered that you want to hear about, please send us an email to info@polarishealthcarepartners.com, or you can always reach us by visiting the website at polarishealthcarepartners.com. Thanks so much for being a loyal listener and subscriber. If you enjoyed today's episode, please leave us a rating on Apple Podcasts, Spotify, iHeartRadio, or wherever you get your podcasts. We'll see you on the next episode of the Group Practice Accelerator Podcast.